Okay.
Okay.
So welcome everyone. This is the second of our meeting. And today we have the pleasure of having Dr. Atul Bhaskar with us. So I will request Dr. Siddharth Yadav to give a brief introduction about Dr. Atul Bhaskar, and then we will start with the session.
Thank you very much, Dr. Atul, for accepting it. And we started the second part. And everybody knows Dr. Atul Bhaskar. And take much time. I think we should start now.
Okay, so my topic is there some disturbance in the mic?
Yeah, I think we'll request all the participants to mute their mic.
Yeah, just mute the mics. Yeah, okay. So my topic is basically on the foot examination, and I'll try and cover some of the topics which commonly come in the exam. So being an examiner for MS, ORTH, and also for the pediatric fellowship exam, the commonest cases which come in the MS are usually a relapsed club foot, acquired flat foot, which is commonly due to tibialis posterior dysfunction. Neuromuscular foot could be either Charcot-Marie-Tooth or myelomeningocele. Polio still comes rarely, mainly the adult polio. You don't see any children poliomyelitis anymore. Alex valgus, only there's one available, and the examiner really wants to harass the candidate. But infections, trauma, post-traumatic deformities are extremely common. Very rarely you'll get a dysplasia or myelomeningocele or an AMC, arthrogryposis, in an exam. So what I'll do is I'll just follow a common pattern of examination of a foot, so that any child which presents with a foot deformity, you're able to make a rough diagnosis from the history as well as from the exam. In a newborn, you will see a variety of deformities, but all these may not be relevant as the child grows up, except for club foot, a vertical talus, maybe Helix Virus, and tibial hemimelia. Hemimelia is always associated with the foot deformity. There is virus deformity, and hence, whenever you get a child with a foot deformity, you always examine the leg, the spine, and the entire body. So coming with the basic history taking, at the end of the history, one should have some amount of idea when this deformity started and what was the progression and what treatment the child has taken. So the onset is very, very important. So congenital problem will present immediately after birth. Certain developmental problems will present during 5 to 7 years of age, typically muscle dystrophy and CP. Then during adolescence, you will get the tarsal coalition, you will get the Charcot-Marie-Tooth. So it's very, very important to know the onset of the disease and whether it's progressive or whether it's non-progressive. Neuromuscular conditions are typically progressive. Whether there is pain on weight bearing, because pain is a very important sign, and pain is only present when there are fixed deformities or the rigid deformities. And absence of pain is only seen in Charcot-Marie disease. So when there is a Charcot foot, you don't get any pain despite gross deformities. Shoe wear concerns is very important part of history. So whether the child can wear a shoe, whether he wears a splint, whether footwear wearing is difficult, because that has a lot of bearing on a treatment. Sometimes parents will seek advice just because the child cannot fit inside a normal shoe or the shoe wear is painful. And of course, family history. So neuromuscular conditions, club foot may also have a positive family history in about 1/4 of the cases. So it's worth having a good history, especially with the onset, progression, and pain. And that gives a lot of information about the tentative diagnosis. So things like club foot will be present at birth. Myelomeningocele will always present with a scar, but the deformity comes later on because foot deformity is usually present during age 2 to 3 years. And sometimes with the very severe congenital deformities, the child may present during adolescence with rigid deformities. So it's worth having, performing a head-to-toe examination, and a thorough neurological examination is important as well. And I'll touch upon that. If you follow the Apley system, Apley was always look, feel, and move. So first part is always look, and you start, you have an order in your mind whether you want to start with the forefoot or the hind foot, and always follow a pattern. So you can go from the front to the back of the foot. You look at the footwear, And then after you do all the inspection, you go for palpation. You do the range of motion, which I'll come to it with specific joints. Again, always do a motor as well as sensory examination. Again, important for minor meningocele and neuromuscular foot, where you should know the dermatomes, where there is loss of sensation. So the L4, L5, S1, and S2 dermatomes. They basically supply from the medial to the lateral side of the foot. Look at the lower limb axis. So you can see the child in weight-bearing position, whether there's any genu valgum, and whether the foot deformity is secondary to a lower limb malalignment problem. Test, special test, I'll come to that. And also always examine the gait of the child. So you have to look at the gait, both in stance as well as the swing phase, because certain muscles act in the swing phase and certain muscles act in the stance phase. So this gives an whole idea how you examine the foot. So start with the inspection part, and again, you've got 2 feet, so always see whether it is unilateral or bilateral. Most problem which are congenital and neuromuscular will affect both the feet. If you have one-side foot problem, it is usually acquired. Very rarely you get congenital problem, but you must think of acquired deformities when they are unilateral problems. So looking at the child, first look at the child in the non-weight bearing position, and then you make the child weight bear. And you start with the forefoot. So look at whether the feet are pointing inwards, the toes are pointing inwards or outwards. Look at the medial crease, the arch. Look at the hind foot, the heel position, and the posterior crease. Always inspect the skin, the tendon, and the nails, because that gives a clue about the diagnosis, especially with rheumatoid arthritis, JRA, with the skin breakdown, with myelomeningocele, neuropathic foot, you'll have skin problems. Again, you look at the callosities of the skin, which I'll come to. Look at the bony contour of the foot, whether it is in equinus, whether it is in cavus, whether it is in varus. Always compare the normal foot for size and shape. So if there's one side deformity, only look at the size and the asymmetry, because that will tell you whether the deformity is long standing, whether there's any muscle wasting. And then you make the child weight bear, and then again you look at the child. So look for any, and also look for any operative scars. So when you make this child weight bear, you can look at the muscle bulk, whether there's any atrophy. You can look at the gait. So there are certain patterns of gait which are seen in neuromuscular foot. And then look at the callosities, because that will tell you about abnormal weight bearing, abnormal shoe wear, abnormal orthotic wear, and whether there's any instability on walking. So when the child walks, suddenly his ankle gives way. This is very, very commonly seen with tarsal coalition, because the hind foot is stiff and they get recurrent ankle instability. So when you look at the child, typically of a clubfoot child, you start with the forefoot and you see the toes are pointing inwards. The midfoot, there's a deep medial crease, there is cavus there. And then look at the hind foot, where there is equinus and there's a deep posterior crease. So you form a pattern where you start from the front and go towards the back, and then comment on the leg, on the atrophy of the leg and the size of the foot. Similarly, if you get an older child who's been under treatment, don't forget the skin condition as well. So you can see there's a skin sore there because of poor fitting of the splint. You can see there's a abnormal bony contour here. The lateral talar head is very, very prominent. The toes are pointing inwards. Again, there's the midfoot is adducted and the hind foot is equinus. And this probably is the commonest case you will get in the exam. Also, you examine the child from the back, so you can see the severity of the deformity. All of us should be aware of the Pirani score, which I will not go into detail, but one should be aware of the Pirani score in case they ask you how severe is the clubfoot. In an older child, you will see the typical deformity, which is in a relapse clubfoot, where the child presents with the lateral border of the foot is turned inwards, indicating forefoot intoeing. Again, look at the midfoot, look at the crease, and look at the hind foot. So look at the foot in all the directions. You can look at the foot from the top, from the side, and from the back. And this will give you a fair amount of idea wherever the callosities are. But sometimes you may find callosities and trophic ulcers on the plantar aspect. This is very, very common with myelomeningocele, where there are bony deformities causing skin changes and trophic ulcers. So don't forget to look at the sole of the foot. And then on weight bearing position, you must look at the weight bearing stance, look at the lateral border, the medial border, look at the tendon prominence, look at the midfoot if there's any collapse, and look at the great toe. So you must comment on the attitude of the foot in standing. So if this is pointing inwards, so there is an in-toeing of the foot, which may be because of the foot deformity or maybe because of tibial deformity. Then you look at the lateral border, then look at the hind foot, and then any callosities you see. So in inspection, you must get a fair amount of idea whether this foot is rigid or flexible, because if you see callosities, you know that this foot is rigid. There is some abnormal loading of the foot on weight bearing or with wearing footwear. So you get a fair amount of idea. So when you get a foot like this, you must mentally be prepared. You know that this is a rigid foot and what other possibilities can be in terms of diagnosis. Similarly, if you look at the planar valgoid foot, this child is a minor meningocele child, and you can see again from the forefoot, the toes are pointing straight. There's a callosity here, there's a trophic ulcer because of shoe wear. The midfoot is collapsed and the hind foot is in valgus. And similarly from the top, you can see the similar signs. The forefoot, the helix is pointing downwards because of weakness. There is a lack of dorsiflexion of the great toe. So these children, when you look at the foot in weight bearing, you will see the arch is collapsed, and you must comment this in the inspection as well. And if you look at the arch of the foot, typically a normal foot will have almost 50% of the arch of the foot is non-weight bearing. And with progressive loss of arch, you will find that the medial border becomes convex. So you can actually grade the arch of the foot from mild to severe. And the most severe is when the medial border is convex. And in the past, we would do foot impressions. So if you have one side deformity, you do a foot impression, and you can measure the length of the foot, you can measure the weight of the foot, and you can also see where the foot is weight bearing. So this is a good way to, if you want to impress the examiner that I would like to do a foot impression and further assess the deformity and the pressure distribution of the foot. Again, if you look at the severe flat foot, you will find that the lateral border becomes concave. So the lateral border here becomes concave, which is here, and that tells you that the foot is very, very severely collapsed. And this is very commonly seen in tibialis posterior dysfunction, in planar valgoid foot because of cerebral palsy, or in minor meningocele. So this is, it's important to remember the severity of the deformity when you see this kind of pattern. Again, don't forget to look at the slippers or the shoes what the child wears, and sometimes the parents will say that the child's foot is coming off the footwear, and you can actually make out. This is what we had actually described. When the heel is sitting within the counter of the slipper, it looks well aligned. It is symmetrical. When there's varus deformity, you'll get more of the footwear seen on the outer side, and if there's a valgus deformity, like here, you will find more footwear is seen on the inner side. So just from the footwear, on inspection, you can tell what type of deformity this is. And this is very important to assess the child with the weight bearing position with the footwear on. And you can see the leg contour as well. And at this stage, you can also describe whether there's any genu valgum or any genu varum, whether there is any malalignment of the lower limbs. Also, you can look at the crease on both the sides, and you can see whether there's any shortening of the leg. You can compare the popliteal crease. So all that can be completed as part of the inspection, and that tells you how long-standing the deformity is, because these atrophy and shortening are only seen if the deformity is present for more than 2 to 3 years. Flat foot, if you get a child with a flat foot, you look at if the arch is completely flat like this, whether this is a normal flat foot when there is a lot of baby fat, or whether there's a vertical talus. And I'll come to that, how you differentiate. But more common in the exam, you will get is a flat foot which is acquired flat foot. Acquired flat foot is basically because of poor clubfoot treatment, and this is a common presentation where you try and manipulate the equinus correction before the forefoot or the midfoot, and then you break the foot in the center. And when you do an X-ray, you find that the talus is still, the calcaneus is still in equinus, whereas the forefoot is in dorsiflexion. So this is a common case which comes in the exam, is the acquired flat foot, and that is because of poor clubfoot manipulation. And it's also called a rocker bottom deformity. The only way you can assess it is by doing X-rays, because clinically it is not easy to assess equinus of this foot. The other foot we see in practice is the flexible flat foot. And how do you tell this is flexible? I'll come to the special test, but you also must see the child if they're wearing any orthosis. So if a child, besides the footwear, you must ask the parents whether the child is using any orthosis, and that tells you an idea what has been recommended for treatment. And you will also base your management based on what the child is currently using. So you must always inquire whether this child is wearing some kind of external splint. Flat foot, of course, is extremely common in practice, but what is important is the rigid flat foot, which is seen in about 9% of the cases which will come in the exam. So either a vertical talus or a tarsal coalition, and which accounts for almost 25% of the disability. So you won't get a flexible flat foot in the exam, but rigid flat foot is extremely common. And I've seen cases with the maltreated clubfoot, rocker bottom feet coming in the MS exam. I've also seen tip post dysfunction, which is of course seen in the adult. And in the CP child, you will get a planar valgard foot. Coming to palpation or the feel part of apply examination, to look, feel and move. From medical training, we've been taught to measure temperature and tenderness. Of course, in the foot, this is important only for the neuromuscular foot. But the key thing is the flexibility, whether this is a flexible or a rigid foot. And you must have some mental picture about where the bones are located. So you must know where the metatarsals are, where the navicular is. You must have a mental picture of the calcaneum and the talus, so that when you palpate the foot, you know precisely what part of the foot is deformed and where is the main deformity. And then you come to the movement. So after palpation of temperature and tenderness, you look at the movement, and you must record movements again in the order of forefoot movements, where you look at the toes, the midfoot where there is abduction and adduction, and the hindfoot where you look at the subtalar joint for inversion and eversion, and you look at ankle, plantar flexion and dorsiflexion. Of course, you look at the composite movement as well, where you can supinate the foot completely. So that is the combination of inversion and adduction, and then whether you can pronate the foot. And these are important for neuromuscular cases where you have a peroneal spastic flat foot, where you have overactive peroneal tendon and the lack of inversion. Or in case of tarsal coalition, where there's stiffness of the subtalar joint. So you must have a mental picture of the range of movement as which movements are blocked and which part of the foot is more severely involved. Always inspect the toes. So the commonest deformity you get in practice is this cavus foot with secondary toe deformity, where there's hyperextension of the MTB joint and flexion of the IP joint, what is called as hammer toe. So very rarely you will get a single hammer toe. It is always in combination with the neuromuscular foot. Typically, you will see a cavus foot with this kind of typical hyperflexed foot, and this is commonly seen in neuromuscular conditions, namely Shakumari or HSMN disease. One more tip to give you is always examine the hind foot by blocking the forefoot, because sometimes when you look at the foot like this, you may think this is an equinus. Actually, the heel is neutral. It's only the forefoot is in equinus. Again, very, very common in the early cavus foot. So when you get a mild cavus, there's a drop only in the first ray, and you may get only a mild equinus of the forefoot, but not of the hindfoot. So be careful when you inspect mild deformities where the deformity is located. We'll come to the test for the flexibility. So there are some special tests which have been described for the foot. It's called the Jack's test. Of course, look at the foot progression angle when the child is walking. The tiptoe test, and I'll come to that. And don't forget, in a child who has difficulty in walking, is the Gauss test. I have seen MS students fail because they didn't perform the Gauss test for a child who could not get up or walk properly. And this is a test you must know for any child who comes who has difficulty in walking or instability. And as Dr. Coleman would say, always look at the shoes. So if you look at the shoes of a child and you tell the examiner, I want to inspect, see the child's footwear, there you got extra points in the exam. So foot flexibility, to make sure whether the forefoot is flexible or not. If you just extend the great toe, the arch, you should get a medial arch. And that tells you whether there is tightness of the plantar fascia, what is called the Jack's toe raising test. So once you extend the great toe, you should get a medial arch. So if you don't get a medial arch, that means this is a rigid arch, there is a arch collapse, and there is a tightness of the arch muscles. Similarly, when you push on the on the toes upwards, what is called the Clicans push-up test. It tells you whether the deformity is flexible or rigid, because in caver's foot, when you push on the metatarsal heads, the toes will become straight. And that tells you about tautness of the plantar fascia as well as the intrinsics. And if it's a flexible deformity, commonly it can be braced, or you can treat them with tendon transfers. You don't need interphalangeal fusion. So that is why it's very important to assess the forefoot and the midfoot laxity by doing these two tests, what is called the Jack's toe raising test, and also called the push-up test. And that tells you the flexibility of the plantar fascia as well as the intrinsics. Similarly, the tiptoe test, I mentioned earlier that when you have a severe flat foot, the arch is completely collapsed. But if you make this child stand on the toes, you will find that the heel inverts and the arch reforms. And this is a very, very important test to assess hind foot flexibility. So as soon as the child goes on the toes, and because of the interlinking of the ligaments, hind foot will invert or go into varus. And that tells you that the foot is flexible, the hind foot is flexible. That's the more important part, and that the plantar fascia is flexible. So you must know the implications of this test. Commonly, if you have a tibialis posterior dysfunction, the patient cannot perform this test because you cannot go on the toes in the absence of tibialis posterior, weakening of the tibialis posterior. And you'll find that the heel may not raise up to that level and the heel may stay in valgus. So it's again important for any medial side deformities, any deformities which involve the tendon of the calf, the tibialis posterior, or the rigid plantar fascia. No examination should be complete without doing a power assessment and a sensory assessment. So you must examine the tibialis anterior, the tibialis posterior on the medial side, the peroneus longus and the brevis on the lateral side, and the gastrocolius on the hind foot. And then you come to the toe extensors and the flexors. Sensations are again important mainly for the neuromuscular foot. So you must perform these tests. And in case there is a neuromuscular foot, you will be asked to perform. And I've seen delegates, failing when they can't examine tibialis posterior. This is probably the most important muscle they will ask you in the exam to test, both against gravity and the gravity eliminated. And this is very important from the management point of view, because if you have a viable tendon, a good tendon for transfer, that will be part of a management. And hence it is important for you to assess the muscle power. If you get a child with spastic foot like this walking on the toes, very rarely you get a CP child in the exam because it's difficult to examine them. But if you get a toe walking child, you must again assess the muscle tone. And what we have, the test of Ashford's test, where you do a rapid stretch, which is called R1, and then you do a slow stretch to R2. And the difference between R1 and R2 tells you the spastic range or the flexible range. So if you have a rapid stretch stopping at R1, and even if R2 stops here, that means that there's contracture, there's no spasticity. So you must have some amount of idea whether this is a spastic foot or a contracted foot. Similarly, this can be done for the knee as well, but right now we will stick to the foot. And this is only important when you get a spastic foot. If you get even a child with the early Duchenne muscle dystrophy, you can check for contracture by doing a rapid test and see where the foot stops in relation to the tibia. Hemovarus foot is the commonest deformity which will come in the exam, and there are various causes. The commonest you will get is HSMN type 1 or 2, but don't forget to look at the spinal cord, because there are cases with cord tumors, with the spinal dystrophism, you can get a cavus foot. Usually unilateral unless it is part of HSMN, which is then becomes bilateral. And when you get a child with cavus foot, again you start with the forefoot, midfoot and the hind foot. So you can see that the foot is inverted. There's a cavus of the midfoot and the hind foot is in varus. But the key thing here in the cavo varus foot is, in terms of management, is to assess the hind foot. And this is where the examiner will always assess you and will test you. How do you test for the hind foot flexibility? So this foot is in varus. So is it really in varus? Or this is a pseudo varus? So this is the basis of the what is called the Coleman block test. So whenever you get a 4-foot pronation or a 4-foot drop, in order to weight bear, the lateral side of the foot also collapses downwards. And you can see what happens. When the lateral foot collapses, the heel goes in varus. And this is basically because what is called the tripod effect. You cannot walk on the ball of the toe. So to compensate, the lateral body will shift down and the heel, which is looking neutral, will shift into varus. And this is the basis of the Coleman block test, what is called the tripod effect of the foot. And you can test it in various ways. You can look at the, you have to know whether the varus is driven by the forefoot problem or whether there's a hindfoot problem. So hindfoot typically will be hindfoot varus because of TA contracture or tibialis posterior contracture. But in the forefoot, it is because of the collapse of the forefoot, because of the drop in forefoot. And you can either do a test where you keep the lateral body weight bearing. There's no weight bearing on the medial side, and you see the heel corrects into valgus. And here you see the heel is in varus because the forefoot is weight bearing. As soon as the forefoot goes off weight bearing, the heel comes to neutral. So this tells you that the hindfoot is flexible. This is a forefoot driven varus, not a hindfoot driven varus. And if there's a hindfoot driven varus, there are only 3 causes: TA contracture or a tip post contracture. Very rarely a TA or tibialis anterior contracture. And you can do this test in various ways. You can do what was described by Coleman, where you get the forefoot of a block, or you can do it as described by Carroll. Where you take the foot off of a step or a stool, so that sometimes you may not have a block available in the exam, so you may have a small platform. And similarly, if the forefoot is off weight bearing, you look at the foot from behind and make sure that the heel is in neutral or is in varus or valgus. Again, only look at the foot progression angle. So when the toes are pointing inwards, when the child walks, this is called an in-toeing gait. Typically, the foot point 15 degrees outwards. If it's pointing inwards, either it is because of the foot problem or because of tibial torsion. And that again, you have to assess the tibial torsion by assessing the bimalleolar axis between the malleolar and the thigh. So thigh foot axis is important. Normally the foot is pointing 15 degrees outwards. So any in-toeing gait, any in-toeing position of the foot should tell you that the medial side is overactive, that the medial side there is a contracture, or the tendons are tight on the medial side. And that tells you you can do your management based on that. Lack of hindfoot inversion, again, like I told you about the Tiptoe test. So this child, you can see when he stands, both the feet are in valgus. As he goes on the toes, the heel is still in valgus. There are only 2 conditions which will cause this in adolescent. One is tarsal coalition or a stiff subtalar joint because of infection, or tibialis posterior dysfunction. So if you have a heel in valgus with a tiptoe, the commonest condition in adolescent is a tarsal coalition, and it could be either a calcular navicular coalition or it could be a subtalar coalition. Some other tests which will come in rare cases is Helix Virus deformity. When you push on the great toe, you'll find the tautness of the abductor hallucis tendon, what is called the Lichblow test. Very rarely you may get this unless the examiner is a very orthopedic surgeon, but very few cases come of Helix Virus in the exam. It's a very, very rare condition. It is an isolated condition opposite of Helix valgus. It is a tight band here on the medial side, and it is typically the abductor hallucis tendon. Again, this is a test which we had described in a poster where if you make the child sit cross-legged, typically you would find that to sit cross-legged, the hind foot should invert. But if it doesn't invert, you will find the knee is higher on that side. And this is because, again, in adolescent, you will find that if there's a tarsal coalition, they can't invert the hind foot, which is similar to not inverting the hind foot on tiptoe. So here you see the knee on that side will be at a higher level. And this tells you that there is a foot problem with inversion. So you can make a child squat as well and see whether there is problem in squatting because of the foot deformity. So this will tell you that, and the child will complain of pain as well, and how the foot deformity can impact even the childhood sitting. So, these are points which will give you credit in the exam. So this is an example of what talo-calcaneal coalition on the medial facet. This is the commonest coalition you get. And here you can see there is narrowing, but there is no coalition. And you confirm this with a CT scan. Of course, again, some rare condition. Don't forget to look at what is called congenital amputees. You look at constriction bands. If you get a case like this is what is called an amniotic band syndrome. It can be a spot diagnosis. Don't say this is a clubfoot. Say this is a syndromic clubfoot because there is these atypical bands which may be present elsewhere in the body as well. So they lead to auto amputation. You can get something like macrodactyly. Again, localized gigantism. Again, part of neurofibromatosis. So you must rule this out as well. So look for cafe au lait spots. Look for spine. Sometimes you get like this Helix Virus. This child is presented at around 12 years of age. You can see previous scar of surgery. So this can come as an exam case. Don't say this is an untreated clubfoot because if you look, the deformity localized only to this area. So this can mimic a clubfoot. This can mimic a metatarsal adductors, but you see the gap here between the great toe and the index toe. You don't see this in metatarsal adductors. This is only seen in Helix Virus. So these are some rare conditions which can come as a spot case in the exam. Again, like I mentioned, don't forget to look at the leg. Sometimes the genu valgum may cause a flat foot. So malalignment of the lower limb, the way the child is standing. If you look at the crouch position where the knee is flexed, the hip is flexed, and the ankle is in dorsiflexion. And here again, the gait becomes important. So when you look at the child's gait, whether this is a spastic gait, whether it's a high stepping gait, whether it's an equinus gait. So that's why the gait examination becomes important for foot examination. So in summary, when you analyze a foot deformity, you must know whether this is deformity uniplanar, whether it's equinus or dorsiflexion, whether it's biplanar. So whether equinus with either varus or valgus, or calcaneus with varus or valgus. In the exam, the commonest deformity you get is equinovarus. Very rarely you get equinovalgus. Whether it's a triplanar deformity, so again, equinocavovarus is the descriptive term for a triplanar deformity. Very rarely you get a calcaneocavovarus. This is very, very rare. So with a triplanar deformity, normally it's both equinocavus varus and adduction. So you must analyze the deformity in this way. You must see the zone which is affected, whether it is the hind foot, so ankle and subtalar, it's the midfoot or forefoot or the toes. So you form a pattern in the mind, starting from the hind foot to the forefoot or forefoot from the hind foot. And analyze each zone that is affected because the treatment will be based on which zone of the foot is more affected and what you can offer. And lastly, whether it is fixed or flexible, whether it is spastic or contracted, whether the foot is braceable or unbraceable, look at the skin condition and look at the proximal effects on the tibia and the knee. So I think with that, this is a summary of the foot disorders you will see in practice. This is the whole spectrum of condition which we see, but may not come as a case, but may come as an X-ray. So Coleman's disease comes as an X-ray. Excessive navicular can cause acquired flat foot. Tarsal collision already mentioned. Very rarely you get ankle instability because of OCD or the talus. So sports injuries can present like this. Sever's disease won't come as an exam. Ankle instability, again, always think of tarsal coalition. Club foot is the commonest thing in the exam. So relapse club foot. You must know the Pirani classification. Vertical talus again will come as an acquired flat foot. Normally, an older child with either will be treated or non-treated. Cavovarus, commonest is myelomeningocele, Shakomari, and polio, in that order. So that completes more or less the spectrum of foot disorders in the child. If anybody asks any questions, I'm more than happy to answer any questions if anybody has. So with that, I end my talk. If you want to send me any messages, you can always take an advice on the phone or on the email. Thank you very much, Dr. Agnevesh and Dr. Siddharth. Thank you.
Thank you very much, Dr. Atul. It was a very extensive and very nicely composed lecture. So if there are any questions, then participants, they can unmute themselves and introduce themselves and then ask the questions to Dr. Atul Bhaskar.
I just stop sharing the screen. Yeah. So I'm not sure how much pediatric food comes in the exam, but being an MS examiner, I've seen Relapse club foot, where there'll be a lot of scars, previous surgeries done, they always come as an exam case.
So one question which I want to ask you, Dr. Atul, is that if in exam, can you sort of mentally categorize the children as per their age and their probable diagnosis? Like it's just the trick. I'm asking you a trick that can you sort of have a general that in say till 5 or 6 years, these are the most the presenting pathologies.
Exam point of view, typically you'll get a child who's going to cooperate in the exam. So they will not give a child less than 2 years. I've seen children usually coming at 5 to 7 years. So you get a child of 5 to 7 years, it'll most likely will be relapse club foot. If you're presenting first time without any scars or sinuses, you can get a short case, which is a Duchenne muscle dystrophy, where I've seen delegates fill in to do the Gowers test, and they call it a spastic foot. Older child you get during 9 to 10 years of age will be typically either post-infection or post-trauma. So commonest trauma will be either a mid-foot injury, which a child has occurred during while playing and got an acquired flat foot, or a child who's got infection in the midfoot, or osteomyelitis or TB, which will come in the less than 10 years of age group. I've seen in adolescent fungal infection, maduromycosis presenting with sinuses. I've seen tarsal coalition come as a long case as well as a short case in the exam. And of course, neuromuscular Charcot-Marie is a very, very common condition which comes in the exam. And I've seen KO virus foot presenting, almost in every MS exam I've been, I've seen a KO virus foot. Either it's post-polio or it's post-HSMN. Very rarely you get CP child. If they're good cognitively, they will give you a CP child. But otherwise, so broad spectrum would be a relapsed club foot, acquired flat foot, infection, trauma, and neuromuscular in that order, if you ask me.
All right. And what sort of advice you would like to give to the residents regarding the examination of spine in these cases? Since it's my field, so let me ask this question to you.
So commonly I find these 3 or 4 points where students miss they don't examine the gait. One thing is they will finish the examination, they'll finish the palpation, and they'll say, my diagnosis is this. And the examiner will only ask one question, did you see the gait of the child? And they forget the gait. And that gait may be because of spinal dysplasm. The child may have weakness. They may have shortening because of they have a high steppage gait. They are not examined. And then the examiner will ask you, did you strip the child? Did you see the back? And they'll find a small dimple in the back, and you'll find some relation to spinal dysplasm. So, you get a mild foot. And this is a trick thing, they in the short case, they will put a foot deformity. But you may either have a cafe or spot, or some nevus in the back with the candidate forgets. And examiner will say, okay, just see the foot and what do you think? And a smart candidate, as soon as he sees the leg, the leg has got atrophy, the size looks smaller, it is one-sided. Let me think of other cause as well. So these things are, I would say, from the exam point of view, I've seen delegates miss those things. Other thing is they don't see the plantar part of the foot. They only see the foot from the front, the back, and the side. And they'll forget to look at the plantar aspect, and you'll find a small trophic ulcer or a callosity, and which is indicative of a bony deformity. And the examiner said, did you not see the sole of the foot? And they completely missed it. So these are because it's not a difficult case. Everything is obvious to your naked eye, but it's the small points like not seeing the gait, the spine, the skin, the sinuses, where I've seen delegates making blunders. And they will lose marks on a good case.
Right. And sort of what X-rays or can come in sort of pediatric X-rays or foot X-rays can come in, say, Viva or as a spot examination?
So commonly, again, when you get a spot examination, they will. I've seen Sever's disease. So in a pediatric age group, they will always show you a normal X-ray, and just tell you the child has got hind foot pain, and what do you think? And people will say this is a normal X-ray. Then they will show you a UBC, a cyst in the calcaneum, again, which is an uncommon sight, and they'll say what is this X-ray. And the spot diagnosis is Kohler's disease. When you had a avian of the navicular, again, is very, very common spot diagnosis. Accessory navicular bone, again, is a very, very common spot diagnosis. Tarsal coalition, very, very commonly missed as well. People will not see it. So where they may have a fibrous coalition, they will have these beaking of the navicular and the talus, when there is a not full-fledged coalition. Those kind of exercises are important. Again, you must also, there are special views. Sometimes the examiner may ask, how do you look at the hind view? So you must know what is called the Harris view. You must know what is called the axial view. You must take an internal oblique view to look at the subtalar joint. So there's some special views there. The person is doing well. They may ask you, how do you look at the hind foot? Because hind foot is not easy to see on a lateral view. You must do an internal oblique view or what is called the bowler's view as well. Look at the hind foot or the subtalar joint. So these are X-rays which will be commonly asked in the exam, and spot diagnosis is accessory navicular, tarsal coalition, and I would say Sever's disease are the three most commonest congenital problems they will ask.
All right. Thank you so much. It was very exhaustive and it was excellent presentation. Over to you, Siddharth, sir.
Unmute yourself.
Thank you very much, Dr. Atul Bhaskar, and it is always pleasure. And we'll continue this. This is the second lecture in this Ortho PG teaching program, and we will further take your time and advice. And thank you very much. And it is all recorded, and it will be there on the channel. So it will be really very helpful for all the postgraduate and all the students. Thank you very much.
Thank you. Thank you. All the best. Have a safe day.